Good afternoon, everybody. I just want to say thank you for taking the time to come out today. My name is Aquarius Gilmer. I'm the Director of Government Affairs and Advocacy at the Southern AIDS Coalition. And today we are going to be, this congressional briefing is being presented in collaboration with the National Association of City and County Health Officials, the National Association of State and Territorial AIDS Directors, AIDS United, and the Center for Health Law and Policy Innovation of Harvard Law School. And again, I want to say thank you to our sponsoring senator's office, her staff, for their responsiveness, their availability, and their attention and assistance given to us. I also want to say, again, thank you for you all coming here. You all work very long hours and do a lot of things, and I just want to say thank you for the work you do every day that we don't see on the public what it is that you do. So I want to say thank you again for that. Today's presenters are Gretchen Wise, Mike Wire, Dr. Jagadija Dakas, and Dr. Bambi Gaddist. And each of them you will hear from today after I get out of the way. But I want to just describe to you what the mission of the Southern AIDS Coalition is, and that is we work to create, working together to end the HIV epidemic, in the South. We envision a South where every person has access to high quality health care and essential support services free from stigma and discrimination. We also envision a South where every person understands their risk transmission, receives routine screening, and has access to full range of prevention, interventions, and harm reduction services. We do this work through several veins, and one of the areas of our work is capacity building assistance, leadership development and education, research and evaluation, strategic grant making, and today I want to focus and center our time on our intersectional advocacy. At the federal level, we educate members about the unique needs of the South and the importance of policies designed to reduce HIV-related disparities and promote greater health and qualities of life for folks living in the South. Our work is often focused on ensuring that the South receives adequate and equitable funding to mount an effective response to end the HIV epidemic. This focus is also consistent with the National HIV/AIDS Strategy, which is updated to 2020, which calls upon the federal government to review the methods used to distribute federal HIV funds and take steps to ensure that the resources go to states and localities with the greatest HIV burden. From Ryan White reauthorization to targeted CDC investments to HOPWA modernization, we have garnered national attention and secured critical resources for the South. But more remains to be done. The South still has the highest burden and amount of folks who are dying from AIDS-related deaths, the greatest amount of comorbidities, as well as abysmal health disparities. We work at the state level, regardless of what the progress is or lack thereof, we experience at the federal level, because we also understand that states too have their part in this plan. Through our joining hands, which is the HIV Advocacy Network of the Deep South Initiative, we are working with networks from across the South to regularly exchange information, share best practices, coordinate efforts, and stretch scarce resources, and ultimately help each other secure the investments and the systemic policy changes that are needed in our states. And most importantly, we know that the successful systemic change begins with the grassroots organizing at the local level in support of critical issues that directly impact the health and wellness of the community. From the earliest days of this epidemic, the leadership of people living with HIV has been profoundly influenced the planning and HIV prevention and care services on the national, state, and local levels. While the needs of people living with HIV have evolved over time, their diverse perspectives and experiences continue to be an integral part of the program planning and implementation at all levels. Here at SAC, we remain committed to meaningfully involving those people who are living with HIV/AIDS in all of our aspects of the response to this epidemic. This is why we are leading the charge to ensure that people living with HIV in the South are engaged and their voices are heard. We do this through four public policy priorities, which are to increase the awareness of the disproportionate impact of HIV in the South, the need for new flexible resources that can be used to mount an effective response to the epidemic. Secondly, we do this by protecting and promoting access to high-quality health care and essential support services, including the Ryan White program, Medicaid, Medicare, the ACA, and private insurance. Thirdly, we work to ensure that Southerners living with HIV and other marginalized communities are free from stigma and discrimination. And lastly, we work to protect and promote access to a full range, of prevention interventions and harm reduction services across the South. During his State of the Union address, President Trump announced on February the 5th that his administration had a goal to end the HIV epidemic in the United States within 10 years. The Department of Health and Human Services subsequently released Ending the HIV Epidemic, A Plan for America. In the first 5 years of this initiative, the initiative will focus on high-burden HIV counties and 7 states with a substantial rural epidemic. Notably, nearly one half of the counties, 23 of the 48, DC, and 6 of the 7 states are located in the South. Consequently, the success of the plan is ultimately dependent upon the success of the South. Today's data has been brought to us by our partners at AIDSView, which is aidsview.org. You can see all kind of really cool, innovative data that we'll be sharing out with you throughout the program. So today's congressional briefing is in response to the President's announcement and has been designed to lay out the tremendous opportunities and intransient challenges that are confronted with the South, HIV in the South. I must make a disclaimer that these solutions and challenges being presented today are but a few and are not exhaustive. You will hear terms today such as U equals U, which is undetectable equals untransmittable. A person who is living with HIV, who has their virus suppressed, cannot transmit, cannot infect, or cannot pass HIV to anyone. That is scientifically proven. You also hear terms like PrEP and PEP, and terms like the social determinants of health, all of which, if we can use and address holistically, we can meet the goals of the administration's plan to end HIV in America. So the goal of the plan is to reduce HIV by 75% in the first 5 years and by 90% in the next 10 years. Subsequently, over this time frame, we will prevent HIV in more than 250,000 people if this plan is successful. Here we see in this data set where the burden of HIV is most directed. If we look in the corner that says the South, 48% of those counties, of all the counties that have been targeted, are there. Here the disparities are even amplified. We see the darker shades of purple represent where the greatest incidence, prevalence, and so-called the clusters of HIV are. The other areas, such as the states that have been identified earlier, are statewide plans that have been generated and created to help to address HIV in high rural areas within the South. In 7 of these states which have the highest rural burden of HIV, we see them amplified here, that the national poverty rate in these states is higher than the national average. Also in these same states, you have more persons who are uninsured. So in response to the President's announcement and the administration's work to end HIV in America, the Southern AIDS Coalition is working together with these partners and others to produce what we're calling the Southern Solutions Meeting, where we are bringing together to bear all the folks who are named in the said plan from year 1 to 5 to Birmingham, Alabama, to discuss what will be needed to actually have a mounted response that can adequately address HIV in the South. This is the information to say the date for that day, and I can tell you that we have quite a decent showing of folks, nearly 150 people who are going to be with us in Birmingham on that day to hear from federal officials about their commitment from their agencies and how they're going to address HIV from their vantage point. I'd like to now introduce Gretchen Wise, the Director of HIV, STI, and Viral Hepatitis at the National Association of City and County Health Officials at this time.
And for my portion of this briefing, I will discuss the role of local health departments and the local public health systems in ending the HIV epidemic in the South. Local health departments, which you may also hear me refer to as LHDs, are on the front lines of public health, and NACHO's mission is to improve the health of communities by strengthening and advocating for the approximately 3,000 local health departments across the country. Through this work, we seek to improve the public health system at the local level. The ETE initiative is described as a whole of society initiative, and it absolutely will take all of society to achieve its goals, but it is at the local level where the work takes place, where communities are mobilized and where individuals are receiving services. Strong public health systems are therefore required for the success of this initiative and for ending the HIV epidemic in the South. Public health systems are commonly defined as all public, private, and voluntary entities that contribute to the delivery of essential public health services. Many of these entities are captured in the image here at the bottom of the slide from the CDC, and it will take meaningful involvement, engagement, participation, and leadership from all of these entities to ensure the success of this initiative, particularly in the South. And we should also recognize that new partners must be sought out and engaged in this work as our needs and our communities continue to evolve. Since the focus of this briefing is on ending the epidemic in the South, I want to address that public health looks different across the country, and the South can look different than the rest of the country as well, as is shown in both of these maps. We often say that once you've seen one health department, you've seen one health department, but we can also quantify in detail some of these differences, which is important to be mindful of in terms of program implementation and policy development. So the map on the right shows the governance of local health departments by state, such as shared government structure in the teal, where all local health departments in the state are governed by both state and local authorities, as opposed to state governance, which is in the greenish yellow, where all local health departments are units of the state. So governance structures do not necessarily dictate health outcomes, but just as we take differences in health outcomes into account when planning public health interventions, which is what we are doing with the map here on the left and the prioritization we need to put into addressing HIV in the South, we also need to take information about local public health systems and consider that in the development of planning and policy. Funding and plans to end the HIV epidemic will require flexibility to work in the variety of environments for policy and program implementation, and we certainly see a variety of environments across the South. Regarding the role of local health departments within public health systems, they can be thought of as community chief health strategists. They are certainly not the only entities working in this capacity, but as chief health strategists, local health departments are well positioned to work with a broad array of allies to undertake public health initiatives and to explicitly address upstream social injustices and the social determinants of health, which is of the utmost necessity if we are going to end the HIV epidemic in the South and across the country. So as already been said by Aquarius and will continue to be said throughout the briefing today and on, we have the tools to end the epidemic, but we must actively address the social, political, historical, and environmental context in which they are implemented. And this work is going to require that our health departments participate in and support community-based coalitions that examine health data, set goals, and develop plans to improve health. This is taking place across the country, and it is what each of the jurisdictions prioritized for this initiative have been called on to do. So what will it take to get there? Of course, we will need increased funding. These graphs depict significant budget cuts and job losses experienced by local health departments over the past decade. And while they have tapered off in recent years, we know that an infusion of resources will be required to ensure a strong public health infrastructure for our ending the epidemic initiatives. I want to really emphasize here that while budget cuts and job losses have tapered off in recent years, we have had a decade of reduction in public health personnel and infrastructure. And while we have seen segments of the private sector rebound since the recession, our health departments have not. They have not made back those losses, which is why new funding to rebuild and to rehire from the local community is so critical to the success of this initiative, and this doesn't just go for health departments. But funding alone won't address the challenge or realize all of the opportunities to end the HIV epidemic in the South. We know that political will, enhanced and new partnerships, meaningful community engagement and leadership, and innovation, among others, will be required. So what are local health departments doing to end the epidemic? I want to quickly run through some data here to highlight local health department services that are foundational to our efforts to address HIV. So for example, we see that the vast majority of local health departments across the country are testing for HIV and other STDs, and that a substantial number are providing treatment for HIV and other STDs. And in all cases, which you'll see in the blue boxes here, these percentages are significantly higher among local health departments serving jurisdictions with populations over 500,000 individuals, which is the vast majority of the jurisdictions, the counties that have been prioritized for this initiative. And as ending the epidemic plans are developed and refined and monitored and continue to progress, we have an important opportunity to assess how these services are being provided, what challenges local health departments and their community partners are experiencing in their provision, and what adjustments can be made to ensure that they are provided at the highest quality and reaching all of those in need. All right. So while the data in this slide is quite a few years old, I did want to share it as it points to some of the challenges to ending the HIV epidemic in the South, but also some of the opportunities. So in 2015, NACCHO, in partnership with the CDC, undertook a national survey with 500 local health departments to accept their engagement in PrEP implementation. And we defined engagement as being involved in implementation in any manner. 284 local health departments responded, and of those, 29% of local health departments said that they were currently engaged in PrEP implementation. Of those that are currently engaged, we see that engagement differed by the size of the jurisdiction served as well as geographically, with only 33% of the respondents in the South that only 33% of those that responded that they were engaged in PrEP implementation being local health departments in the South. Now, this survey was conducted just about a year after CDC released the CDC PrEP guidelines, and while we know that PrEP has scaled up across the country, we also know that it has been inadequate and uneven, particularly in the South. We did want to get a sense from our members what their intentions were to expand their engagement in PrEP implementation. So on the left, you will see that nearly half of the local health departments in the South currently engaged in PrEP implementation at the time we surveyed them in 2015 said that they did intend to expand implementation efforts. And of those not currently engaged, and I see that the numbers aren't quite showing up here on the slide, but 26% intended to become engaged in the next 4 years. We're currently working with the CDC to conduct this survey again with a larger number of local health departments across the country, and we'll hope to be able to show some of the progress that has been made in terms of the percentage of local health departments that are engaged in PrEP implementation, but then also learn what it is that local health departments are doing, what challenges they're experiencing, what resources and additional support is needed, and work with our partners here, you and others, to ensure that this information is incorporated into the Ending the Epidemic plans. So in conclusion, I want to end by bringing this back to the role of local health departments as community chief health strategists, and take this opportunity as a call to action for local health departments in the South and across the country to continue to grow and expand in this role, working in close collaboration with their community partners and the entirety of the public health system to end the HIV epidemic. Undertaking the practices required to be effective community health strategists, which are listed out here, will require additional funding and support from Congress, HHS and other federal agencies, the group represented on this panel, and many more, to ensure that we collectively have the ability and the capacity to come together as strategists for this initiative and for our communities. I've also included here an image of the 10 essential public health services as another critical framework for thinking about organizing our work at the local level to ensure that there is a strong public health system to support the work that is taking place. And I will just end by saying that since the announcement of the Ending the Epidemic initiative in February, NACCHO has worked closely with our local health department members in the prioritized jurisdictions, the federal partners leading this initiative, and our national partners to support its success. A priority for us has been and will continue to be serving as a resource for our members, learning from what is working on the ground and what is not, sharing that information, hearing from others about what is working and what is not, and then working together to realize the opportunities of this initiative and confront the challenges that we know. So thank you very much for your attention.
Good afternoon, everyone. My name is Mike Weir. I am a senior manager on NASDAQ's Policy and Legislative Affairs team, and I'd like to thank SAC and everyone for being here today. So just a little bit of information about NASDAQ. So we represent governmental public health officials who administer HIV and hepatitis programs throughout the country. We have members in all 50 states, DC, Puerto Rico, the U.S., Virgin, and Pacific Islands. So just a little bit of information about jurisdictional ETE plans. And so the time to end the HIV epidemic is now, but it will only happen through collaboration of community and health departments. And we have seen this collaboration, I don't know what happened to the slides. We have seen this collaboration already starting with jurisdictional ETE plans. And these plans have been happening both at the state, county, and city level. And once we get the slides back up, you'll see a map that we house on our website that has all of these plans for jurisdictions that are happening throughout the country. Some core elements that are happening throughout the plans include things like community engagement, which you will continuously hear today, as well as government involvement happening at all levels, not just at the state level, but also at the county level and city level, as well as funding increases and a prioritization of funding. And with the administration's announcement of the federal ETE plan, health departments and the HIV community must start collaborating in a new way. I wanted to highlight briefly a report that NASDAQ puts out annually called our ADAP Monitoring Report. And ADAP stands for the AIDS Drug Assistance Program, which is a part of the Ryan White program under the Part B. In that report, there are nearly 110,000 Ryan White Part B clients and ADAP clients that are served and enrolled in the South. And that's nearly half of all clients that are served by Part B and ADAP. So we do see a large portion of clients utilizing Part B and ADAP services in the South. For many clients, ADAP services alone are not sufficient, and they benefit from the ADAP-funded insurance program, which can address their needs beyond just HIV treatment and can impact their overall health and well-being. And we've seen an increase in the number of clients that are served by this program, and we think that this will continue to play a vital role as jurisdictions work to end their epidemic. Ryan White Part B programs, as well as ADAPs, are also well positioned to address the social determinants of health that influence the HIV care continuum by providing support services for individuals that are living with HIV. And these support services include things like transportation, stable housing, as well as food security. We have a map also on this slide that comes from the report that shows the viral suppression rates, which we mentioned earlier, for clients that are served by the Part B program. And we see that the majority of states in the South are on the lower end of the scale, so less than 85% of their clients are virally suppressed. And nationally, for the Ryan White program, about 86% of clients are virally suppressed. So we do have more work that has to be done as it relates to viral suppression for clients that are served in the South. So what are some challenges that we see to ending the HIV epidemic and for ETE plans overall? So federal and state policies, including those that impact the Affordable Care Act, could impede efforts in achieving ETE goals. All of the 4 jurisdictions with the highest rates of viral suppression are jurisdictions that have expanded Medicaid. Access to health care will also continue to be a challenge with a lack of culturally competent providers, as well as transportation needs, particularly for clients that are served in the South and the distance that they have to travel to receive their care. The opioid crisis will continue to be a challenge, and we've seen increases in diagnosis among injection drug users, both for HIV and hepatitis C. And we've also seen jurisdictions put up barriers as it relates to expanding services for syringe service programs, as well as harm reduction programs. And then also, we will continue to face challenges with the expansion of policies and positions that contribute to stigma and discrimination against LGBT people, immigrants, those seeking asylum, and populations that are disproportionately impacted by HIV. And then finally, what are some key elements that we think must be included for jurisdiction and for the implementation of this ETE plan? And in addition to federal policies, health departments and HIV community members must coordinate efforts both on local and state policies, especially those that address HIV criminalization and syringe service access. We must focus on evidence-based strategies, and these include things like U equals U, which we mentioned earlier, undetectable equals untransmittable, as well as treatment as prevention, syringe service programs, comprehensive sex education, as well as culturally competent care. A few notes on these is we have worked with many health departments as their general assemblies or state legislatures have worked to update their syringe service laws as well as their harm reduction programs, and we continue to do that as jurisdictions and their state governments do that. We've also, through a cooperative agreement with HRSA, developed a CE credit for medical providers that gives them the opportunity to take a course on what it means to provide culturally competent care for Black gay men, which continue to remain a population that are disproportionately impacted by the HIV. Other elements that are needed to achieve an ETE plan include addressing the syndemics of HIV, hepatitis, and STIs, as well as increasing funding. And increasing funding means for those programs as well, but also increasing funding for structural interventions that many individuals living with and disproportionately impacted by HIV rely on, including housing. And there must be meaningful engagement. And I must say that I think that this is one of the most important themes that you're here today, but meaningful engagement and partnership with communities most impacted by HIV. We will not be able to end the epidemic if the communities that are impacted by HIV are not included and not brought to the table as jurisdictions as well as the administration are moving forward with their ETE plan. And that was all that I had. Thank you.
Okay, so our public health approaches to HIV prevention in the South need improvement. For this administration's Ending the HIV Epidemic Plan for America to be successful, it must address the tremendous health disparities and social determinants of health inequalities that we experience in the southern states. So it'll be imperative for those of the health and plan to work towards improving access to quality health care as an HIV prevention strategy, particularly among Blacks, gay and other people of color, gay and bisexual men, and people of transgender experience. So, my name is Dr. Jagadisha Devasridegas, and I'm a postdoctoral research fellow at the HIV Center for Clinical and Behavioral Studies at Columbia University and the New York State Psychiatric Institute. In addition to being a behavioral science researcher and social scientist, I'm also a social worker and a Black gay man whose HIV-related career has spanned more than 2 decades. As a social worker, I possess an extensive history of working for and with community-based organizations, nonprofits, local and state health departments, engaged in the provision of programs, programs, interventions, and other services for at-risk people of color populations, youth, drug users, lesbian, gay, bisexual, transgender, and queer populations. And today I'm here on behalf of the Southern AIDS Coalition to speak to the need for the plan to emphasize non-biomedical tools and strategies in order to address the HIV disparity in the South. So because my colleagues have done a great job about contextualizing the magnitude of the epidemic in the South, I'm not going to provide any additional epidemiological information. Rather, I'll speak to how imperative it is that the administration not only consider, but also integrate non-biomedical interventions and strategies. That is, interventions and strategies based in behavioral HIV prevention interventions and on science behind those interventions. I come to you as a social worker that has been involved in the dissemination of several of the Centers for Disease Control and Prevention, or the CDC's, evidence-based interventions, or EBIs as they're called for short. For 7 years, I served as a capacity builder, a lead trainer, and technical assistance provider to AIDS service organizations, community-based organizations, and nonprofits that adopted, adapted, and implemented the CDC's evidence-based interventions. So we're here at a place in the epidemic where we have effective biomedical tools, such as pre-exposure prophylaxis, or PrEP, post-exposure prophylaxis, known as PEP, and treatment as prevention for people who are living with HIV, to keep them virally suppressed or undetectable, as we like to say. So these biomedical interventions have been implemented to prevent the acquisition and transmission of HIV among what we call our priority populations. They are Black and Latinx men who have gay, bisexual, and other men who have sex with men, Black transgender women, and youth and young adults aged 13 to 29, distinctly those of color. Even given the advent of these biomedical interventions, particularly in the case of PrEP, adoption of them has been low among our priority populations. Therefore, it's important that the plan consider and utilize non-biomedical interventions that support behavior change through individual and community level education and support. Further, the plan needs to endorse non-biomedical interventions that also have an effect on the epidemic on structural and population levels as strategies. The plan needs to capitalize on these interventions that have been shown to have the greatest impact because they can support and integrate the adoption of biomedical tools, so PrEP, PEP, and treatment as prevention, as a means of supporting and reinforcing behavior change. Now, an effective combination of HIV prevention, that approach includes structural, biomedical, and non-biomedical interventions. This approach to HIV prevention is actually very holistic. It recognizes factors that are particular to the South, such as infrastructure, Southern culture and traditions, and religion. The approach is cost-effective as a high-impact HIV prevention approach. The non-biomedical interventions can be particularly effective when tailored to address the social, community, and structural level factors that place priority populations in the South at greatest risk for HIV. Non-biomedical interventions, tools, and approaches and strategies need to emphasize HIV education, awareness, and the importance of testing to know one's status. This entails access to accurate information via individual and group level evidence-based interventions, HIV awareness public health campaigns, and community mobilization efforts. For example, increased availability of and access to prevention tools such as condoms and sterile syringes has been shown to reduce HIV risk at the community and individual levels. These tools can be particularly effective when they're paired with what we call a status-neutral approach to HIV prevention. A status-neutral approach is a multi-directional continuum that begins with an HIV test and then diverges depending on the HIV test result. This strategy proposes the same simple, accessible, and routine approach for engagement regardless of a person's HIV status, making it effectively HIV status neutral. The outcome is either continued prevention engagement for those who test HIV negative, or HIV treatment for those who test HIV positive. With HIV testing and counseling as a starting point, non-biomedical interventions can be implemented to support HIV negative people with remaining HIV negative, while ensuring that HIV positive people are linked to early and ongoing care and treatment. Tools such as condoms and sterile syringes need to be readily available as part of the status-neutral approach to engaging people at risk or living with HIV. Now, non-biomedical interventions, particularly the evidence-based interventions, have been proven to support behavior change via educational and didactic activities grounded in important behavioral science theory. For example, the trans-theoretical model of behavior change, better known as the stages of change, assesses a person's readiness to conceive of and implement new, healthier behaviors. This model provides strategies and processes for change to guide a person by promoting self-efficacy along a continuum of behavior change stages. It helps move the person from pre-contemplation, or not thinking about it, to maintenance or staying with the new, healthier, and desired behaviors. A counseling approach that is often coupled with the trans-theoretical model of behavior change is motivational interviewing, or MI. MI is a client-centered counseling style for eliciting behavior change by helping people explore and resolve their ambivalence about changing behaviors or adopting new ones. Now, when compared with traditional directive counseling, MI is non-directive, cooperative, focused, and a goal-oriented approach that centers on the person's own desire for behavior change. Now, given my brief descriptions, I hope you begin to get a sense about how integral and invaluable this behavioral model and counseling approach are to many of the evidence-based interventions and other HIV prevention interventions that are out there. In order to support the ending the HIV epidemic plan, our prevention efforts will need to include select interventions and strategies shown to have the greatest impact among people at greatest risk or living with HIV in the South. In other words, a high-impact HIV approach to ending the epidemic. Individual and group-level non-biomedical interventions are paramount as a frontline approach, and usually the ones that are most commonly implemented. However, with the addition of structural and community-level interventions, without them, our efforts will be fruitless. Structural and community-level interventions such as condom availability and distribution, expanded syringe access programs, and partner services are meaningless, and biomedical interventions will not work either unless the plan addresses institutional and structural barriers rooted in the South, such as racism, homophobia, transphobia, and religion. The lack of public health discourse about sex, sexuality, gender identity, and conservative religious ideologies contribute to the experiences of stigma for all people affected by HIV, regardless of their HIV status. In order for the plan to be effective in the South, strategies and mechanisms must be in place to break down the barriers that can effectively deter and/or prevent people from seeking HIV prevention services and/or accessing accurate public health information, which they need to protect themselves and to protect others. Specifically, I refer to HIV counseling and testing, HIV treatment and care, and other ancillary preventative services. And what I mean by ancillary preventative services are those that include physical and mental health care, drug and substance abuse treatment, housing and employment support. The effects of institutional and structural barriers have had a profound impact on people at this individual level. Even if people have access to accurate prevention information, people in the South seeking to access HIV prevention services often cite barriers in the forms of lack of healthcare access, provider bias, poor provider communication, and culturally insensitive care. In the case of Black men who have sex with men, or Black MSM, in the South, studies have shown that Black MSM living with HIV describe perceived and enacted stigma as deterrents to seeking care and treatment and medication adherence. For HIV-negative Black MSM in the South, they also describe perceived and enacted stigma as deterrents, along with medical mistrust and racism as discouraging them from adopting PrEP as an HIV prevention strategy. These experiences of stigma are not unique to Black MSM in the South, although, given the state of the epidemic and the social and political climates in the South, Southern Black MSM arguably experiences differently than Black MSM across the country. Now, because we know that HIV stigma is very, very real, Black and Latino MSM, Black transgender women, and youth of color contend with the effects of enacted, felt, and structural forms of stigma on a daily basis. The plan needs to have provisions that, on the institutional and structural levels, address the race-related, sexual orientation-related, and HIV-related stigma that pervades the lives of these priority populations. Any approach to addressing stigma in the South, any approach addressing HIV stigma in the South needs to be intersectional, meaning that it recognizes the social locations and positions that people from the priority populations have. An intersectional approach to HIV prevention in the South should be premised on the knowledge that these priority populations experience and contend with, to the best of their abilities, interconnected systems of oppression and discrimination, such as racism, sexism, classism, heterosexism, xenophobia, stigma, transphobia, policing, and criminalization. They can be experienced simultaneously based on people's intersecting identities as people of color, sexual and gender minorities, and people living with HIV. The plan needs to recognize the priority population's vulnerability because they contend with multiple and concurrent forms of oppression and discrimination. In closing, I'd like to reiterate how important it is for the ending the HIV epidemic to emphasize non-biomedical interventions, tools, and strategies in order to address the HIV disparity in the South. As with all prevention efforts, HIV prevention in the South needs to be ongoing. A single dose of prevention will not have the impact that continuous HIV prevention efforts will have. Again, it is critical to the success of the plan that it attends to the political, social, and environmental landscapes unique to the South and its priority populations. Although there is no panacea for ending the HIV epidemic in the South, we have a multitude of tools, strategies, and interventions at our disposal to make an impact. Thank you.
I'm the good news. I'm last. I'll also say that I'll consider this being your reality check here. I had the pleasure of talking to a couple of the attendees before we began. And I learned some things. I learned that they're up-and-coming potential attorneys, that they have interests in public health as well. And so I would compel you, as you go back to your offices, I know that some of you have been sent. And I would hope that when you return, that you'll have something valuable to share with whoever sent you. Some of you are going back to your states when you depart at the end of the summer, I understand. And so the question will be, how does this translate, and how will you translate what we're saying to you today? Because for you, it may be just information. For some of us, it's more of a compelling conversation that we have got to have. So again, my name is Dr. Bambi Gaddis. I am CEO of a community-based organization in Columbia, South Carolina. We go by the name of the South Carolina HIV Council, but that's the principle. But we are the Right Wellness Center, is what people see. Oh, that's interesting. Did you change that? Oh, okay. Yes. So I'm honored to be here. I'm representing my board of directors, my staff, and I believe my state. But I also want to speak on behalf of the voices of our clients who come from all different types of ages and socioeconomic status, sexual orientation, race, etc. Because one of the things they all have in common is that they sought services from our community-based organization. And and part of my agenda, as brief as it may be, is to talk about the role of community-based organizations, that when you look at the End the Epidemic plan, we are encouraging to be included in this process. So it's my intention for this brief amount of time to reflect on my experiences I'll be 64 years old in September. I know we're old heads, old school, whatever you call it now. I have a 40-some-year-old daughter, so wherever that falls in the scheme, and I have grandchildren who think I'm cool. But at any rate, 34 years plus in the field, 25 years as a CEO that's celebrating our 25th year anniversary this year. So I wanted to start off briefly, and for those of you that take notes, I'm a teacher by heart. So one of the things I would always ask is, do you have something to write on? But if you don't, you have an iPhone or Android or whatever fits your fancy. So I would encourage you to look up an article. It was in Politico. It was published June 6th of this year by Sarah Carlin Smith. And I wanted to read a brief excerpt. It says, if President Donald Trump's ambitious plan to wipe out the HIV transmission in America by 2030 is to have any chance of success, it will have to reach people like Kawana Dingle's mother. I met Miss Kawana Dingle's daughter, who lived in California, who was referred to our agency by a member of SAC, who had her call us in South Carolina because she could not find her mother and she had heard she had AIDS. In April, she walked into an emergency room in a rural South Carolina hospital. She went to that same hospital 7 times, and 7 times she was refused care. That final time, the hospital called the police and put the homeless woman in jail. From there, she went back to the same hospital where she was placed in a psychiatric ward for 18 days. Frantic, her daughter finally tracked her mother down with the help of the police, only to find that a hospice nurse from somewhere was also looking for her because she wanted to alert her that her mother had HIV. She had kept it secret from her daughter, from her community, from her medical providers, who may have treated her differently had they known she may have been suffering from AIDS-related dementia. I would add that there were numerous missed opportunities where we're trying to figure out, where was she tested? Why was she not tested? How come that many interfaces occurred in a medical care system and she was never identified? So our agency is the first alternative, we are actually the first alternative testing site in our state back in 1995. We were the first CBO, community-based organization in South Carolina, to be funded directly from CDC, and the first to begin oral and rapid testing. We pushed the health department to move to CD4 count viral loads, which is what we use to determine where a person's infection is, where do they fit into the medical treatment paradigm. Until 3 years ago, we were the only organization in the state with a mobile unit that we go into clubs, when you're sleeping, we're up. Nightclubs, under the tree, wherever folks hang out, that's where we commit ourselves to being. That's a picture of our mobile unit. In case you didn't know, South Carolina has always ranked in the top 10 of the epidemic. And in 1998, our city, Columbia, was ranked as high as 4th in the nation. These are just some examples of some of the services we offer. We work with not just HIV-positive individuals. 85% of the folks that come in our office are HIV negative. They are coming to identify their status. So we run an organization in the Bible Belt. And despite our great beaches, I don't know if you've ever come to South Carolina, but we have great beaches and we have Southern charm. But despite all of that, we still are a hot spot, according to President Trump's analysis. So what you're looking at is what one of our main focuses. And one of our main focuses is to infiltrate spaces where people traditionally don't think about HIV or offer HIV. There was a conversation about opiates. Our state has a plan that when I Googled the terms HIV and Hep C, it never came up in the report. And so there's these intersectional conversations that if we don't move into these spaces, if we're waiting for them to come to us, it won't happen. And so the work we have to do is going to those people who sit in positions of authority and try to encourage them to integrate what we do into their paradigm. Some recent innovations, I would say, that we've put in place are mental health clinical therapy. We spoke of alcohol and drug partnerships where we integrate testing into AOD treatment centers, and we're getting ready to partner with the Department of Health on a mobile unit, not a mobile unit, but a mobile app, so that we can look at adherence and try to motivate folks, particularly those who are in care, but also to reach those who are out of care. Oh, that didn't come out well. So let me talk about it briefly. In 4 years, we tested over 8,000. Of those 8,000, the mean age was about 30-some years of age. We found 150 new positives. That does not include the 32 who were previously diagnosed but out of care. Many of the people we serve are insured, but they're underinsured, which means they have needs, but once they meet their cap, they're unable to access. So that's why patient assistance programs are critical. We test all STDs. One of the things that's important that when you go into a physician's office, many times they'll use urinalysis only as the mechanism by which they can determine infection. We have engaged multi-site oral and anal self-exam. We have had a doubling of our detection because we no longer use that one modality as the only way to detect STDs. Hepatitis C is, as you know, in your state, is almost 3 to 4 times higher than HIV. We have to address that as well. The plan suggests that we lost our funding this year because it was redirected. And it was redirected because they're looking for numbers. They're going to federally qualified health centers and hospitals. I suggest that in doing that, we will lose many people who could have been picked up by a community-based organization and directed and linked to care, but our numbers were not large enough. We approached the SCDC in your prison systems 3 years ago and suggested that we get in a partnership of testing for Hep C. That did not happen. And as a result, the federal government intervened, and now they will test for Hep C. They will treat for Hep C. Many CBOs see the writing on the wall, but a lot of times we are ignored. So, can you tell me what you see here? Yeah, I'm engaging the audience. What do you see? You can take a risk. You see a parrot? Okay, so you don't see the woman. You don't see the woman with her arm around her. You don't see her thigh and her leg. You don't see her leaning back. You see it now? Okay. My point is, sometimes people have to bring something to your attention. Sometimes you overlook things. It's right in your face, but you miss it. That is what has happened with this epidemic in the South. It's been in our face, but we missed it. And now we're dealing with the aftermath. I'm a recovering Northerner. I was telling Doc this yesterday. I'm from Jersey. Yeah, I'm a Jersey girl, that's why they call it the Garden State. But down there, they still call me a Yankee. When I went to Tuskegee at the age of 17, one of the things that was peculiar to me is that it wasn't until I left Tuskegee, it wasn't until I finished a master's at IU and started working in HIV decades later that I heard about Tuskegee. They never talked about this study when I was there. We talk about stigma and what we pay attention to. The elephant in the room is what has been addressed. This is real, that people believe that there is a conspiracy. There's a statue in South Carolina. It bears the name of J. Marion Sims. He was a researcher from our state. He is the father of gynecology. He was known for his experiments on African women, where he conducted his research with no anesthesia. And so we give tribute to some things, but we don't acknowledge others, but yet we wonder why people don't trust the healthcare system. And so Miss Wilhelmina Dixon, the picture that you see there, that was her daughter Toni when she passed. We talk about all the innovations that are out here now. How is it? There are people in our state, in Tennessee, in other states in the South, who we think would never end up this way. How is it that we can have all of this innovation and people still don't get access? That sign right there that says AIDS is God's curse to homosexual life, that was a sign that was up in Birmingham in front of a church. And if you look at the photograph in the back, you can imagine what the impact is for all of the people who lived in that community, who walked and drove by that sign every day and what it communicated. So I'm a person that worked for the State Department of State Department of Education. I had my own Benghazi. My own Benghazi was when I was called before the legislature to defend myself against the fact that I was corrupting the children of South Carolina, where I had to give testimony to the fact that we talked about condoms, that we talked about proper use of condoms, that we talked about what real prevention meant, that we had comprehensive school health law. But I'm here to tell you that that is not being followed. It has been dismantled, and we have produced generations and generations of children. I don't know, and New York is the same, who are entering our colleges and into the world unprepared to make choices around their sexual health. They have not been exposed to information that should be just basic. And now we're seeing them enter into our offices at the community-based level, and it is of a grave concern. So they say time is pay now, pay later. We are paying a fortune for not expanding Medicaid. Most of the folks in our state are uninsured and underinsured. We already know, this is a report that came out of the HHS, we already know we can save dollars if we find HIV, if we treat it early. We already know with PrEP, we can prevent new infections, we can save dollars. That has to be translated to your leadership, that we pay now or we pay later. So they have proposed these 4 pillars of the HIV plan. But there's a practical application to it. And so in closure, I can present and talk about, we've talked about Medicaid expansion. There's a couple of key messages I hope that you summed up from what I was sharing. One is, you can write this down. When your congressmen develop their plan and they decide where they're funding their strategy, remove your northern hat or your western hat, because it's not the same. Focus on Southern strengths, but acknowledge that we have a historical legacy of slavery that has yet to go away, and the trauma still plays itself out in the healthcare system. You are developing strategies for a geographical territory with many contradictions. We believe in God, we believe in a higher being, but we still have sex, but we don't want to talk about it. Institutions of faith promote homophobia. We must infiltrate systems as they will not come to us, we have to go to them. We are in need of medical help. We do not have enough physicians and caregivers. Maybe we need to incentivize physicians, just like we do in foreign countries, to go into the rural communities and pay them to be there and to invest their intellect into these communities if we're ever going to address this epidemic. All is not what it appears. You saw that. Southern states have not prioritized HIV as a health disparity, and they have not applied pay now, pay later. So we need to be looking at cost impact. What types of models will reduce costs in the long run, not in the short term? Many citizens are uninsured and underinsured, and they have no plan other than the ER or emergency room. That is not comprehensive care. And then finally, minority-led agencies such as ours, who although we've been part of creating innovation, we are under siege. We're under siege because when we compete with Atlanta, we compete with San Francisco, we compete with New York to get these funds. We've been successful. Many of my colleagues have not. We are under siege by the franchisement of HIV, where folks are making money and they're interested in building territory, but not necessarily totally understanding the elements that have been discussed on this panel, and that it's not just about providing services, it's how you provide them, and do you understand the communities that you are serving. And so I would say, in closure, we cannot solve problems with the same thinking we used when we created them. If you change nothing, nothing will change. Thank you.
Thank you to all of you. That was really comprehensive. And so at this time, I'm going to take the time to let you all ask any clarifying questions that you may have. Yes.
If there are a lot of people that are sort of either don't have access to care, or if they do, there's a lot of internalized shame that accompanies getting tested and treated for HIV. And as someone that's living with HIV, I know for me, it was very tough to sort of navigate that shame to even get tested to begin with. And so I'm wondering, what are some innovative ways that people have been thinking about reaching those populations that are really, they might not know their risk for HIV. Even if they have access to care, there's just so many structures and systems that they have been exposed to that really prevent them from accessing the testing and treatment that they need.
Well, one of the things that we're doing, we're moving toward, we're still writing up the methodology, but we're planning to do a concierge service where we actually go into people's homes, where we have a host home, and that those hosts have designated space where we take a very select few people out of our staff with a case manager, and we are invited in there. They can do their, desserts or their whatever they want, but they will host us. We're in, we're out. So my point is we have to take it to them, not always depend on folks to come in. One of the things I'd like to note in recent months, we're CDC funded, they decided they no longer wanted to support our vans. When we first had vans, we wanted to purchase. Again, back to your leadership and what they think is important. The vans were the mechanism for taking labs, for picking up clients to take them to case management, to picking them up to bring them into support group, and all of these other avenues where southern states have transportation issues. They live in the boonies. So if you don't go to them, pick them up, there's no Uber. So there are things that we need to, as you noted, change the way we do business. This is not the health disparity where we can sit back in our office and think that out of the stigma, that's why we changed the name of our agency. We don't have HIV on our sign. We are the Right Wellness Center. And it totally transformed people coming in. But for the record, it's not just poor folks, and it's not just black folks. Yes, we are heavily impacted, but it is not just us. We provide services to physicians who are into menage a trois. We have businessmen that roll up in their Mercedes and their, you understand what I'm saying? So this stigma is not just about race, it's about classism. And we have to move past that, because the same people who make a 6-figure income are the same people that don't want to talk to their doctor about their sexual preferences, what they love, what they like. So they come to us. That's why CBOs have to be part of the conversation. We are the pipeline into care.
Actually, I'd like to add, it's also not incumbent on the individual who is living with HIV to kind of make that leap. I mean, I think about the work I do with service providers, like medical and non-medical service providers. It's really increasing their cultural competency and sensitivity and ability to ask questions and engage, to make detections if they need to engage their clients or talk about their HIV status. That's one of the things that helps. In addition to that, one of the things, and this is, I'm going to wear my northern hat, that we've done very successfully in New York City is really having very focused anti-stigma campaigns around HIV. So, in addition to making services more routinely available in other locations, besides like clinics and medical facilities, making things available in the community, but also encouraging people to engage in healthcare systems by having themselves represented, by addressing the stigma, by talking about that, we have supportive services where people can engage in care and, engage and live very healthy lives. So that's one of the ways to do that.
I wanted to add to
Sure.
the PR piece that our governor, former governor, she was in your area at one point. There was a community-based organization down in the Low Country, and they had a billboard campaign going on saying that that the county that they were in was third in the state in HIV. She called the director. She said, you have to take that down because we're trying to bring new business into this area and it's an impeding factor. So we get into the politics of HIV and why we need advocacy. Some of you are going to go to your own endeavors. The fact that many of you appear certainly younger than I don't know about you all, but certainly younger than me. You are the core of what we need to have in changing the mentality of what is happening in this epidemic. It's going to be you and your mentality when you go to the legislature, when you go into your law office. I can't name one doctor in my city, one lawyer, not one lawyer that I know of in Columbia, South Carolina, that specializes in HIV law. When our clients are being discriminated against, who are losing their jobs, who have Ryan White paperwork for Section 8, and a landlord says, I don't want you here, I have no one that I can call upon to go litigate for that client. So there is a need for advocacy at all types of levels.
Thank you for that. I just want to ask Mike and Gretchen to maybe follow up around sort of the social determinants of health and how they play out at the local level, and how health departments are actively working to address the social determinants of health, and also stigma related from the folks that they're granting resources to in the communities.
So I would just add that, on social determinants of health, health departments do utilize Ryan White funding to provide wraparound services for individuals that are living with HIV, including housing support, transportation support. The issue that we often run into is that we have to make sure that we're providing the core medical services that individuals living with HIV, and with lack of resources, providing those wraparound services can be difficult. The second part of your question was
Stigma reduction.
Oh, stigma reduction. And so we have done at NASDAD, we developed a stigma toolkit that we have used to help our health departments both internally look at their policies and determine if their policies do perpetuate stigma, but also how can they partner with their community and build relationships so that they can not only work on reducing stigma internally, but also reducing stigma that is occurring outside of the health department and in the communities that they're trying to serve.
You mean in the church?
Depending upon the health department, there are some health departments that do have great relationships with church, but if you've seen one health department, you've seen one health department. And so health departments have varying relationships with communities, and it's something that we do encourage our members to actively participate in and actively make sure that they are trying to reach the populations within their state and within their jurisdictions that are being disproportionately impacted.
Yeah, I would echo all of that and emphasize that it is about looking internally within our health departments, our institutions, as well as externally in the community. And that local health departments, if we think about the local health department as this chief community health strategist in this era of public health 3.0, what is it that local health departments should be doing? And it is absolutely tackling those social determinants of health, getting outside of their four walls. We see a lot of our local health departments innovating from a clinical services standpoint. Not only how can they bring those out into the community and address some of those barriers, whether it be transportation or otherwise, to coming into a clinic, as well as thinking about how can we rebrand some of the services that we are offering. So maybe instead of referring to something as an STI clinic, we're talking about it as a sexual health clinic.
Thank you. Any more questions? Sure.
So I just have a question in the sense of engaging with the community you live in. So in the community I live in is very closed-minded, very like anti-gay, pretty much everything. And our local health department's not very involved with the HIV epidemic and the AIDS epidemic. So engaging in that in the sense of trying to make them more aware, I guess is the better way to word that, but make them more open to that stuff. Because we have, like, growing up, I had friends who were gay, but they, like, had to leave because their parents faced all kinds of stuff in the area because of the people. And so what would you recommend on how engaging even your local health department, if they're not so much advocating for the AIDS epidemic or the HIV epidemic? how would you engage them in the sense of, we need to address this? It might not, in your eyes, feel like we have this big issue, but we do. And some people, especially where I live, don't see it, because I live in the boonies, so literally it's, yeah, so.
You go first.
Okay. Well, I think that part of this, there's an education piece to it, right? So ensuring that, you know, sometimes we do have to educate our local health officials, just as we often look to local health officials and local health departments to provide an education role in our communities. You can refer them to NACHA's website to see that HIV is a priority and should be a priority for local health departments. But I also think this is where working with community-based organizations and mobilizing as a community to demonstrate to the health department it is your job to ensure the health, safety, and well-being of everyone in this community. These are essential public health services, and we need to work together to provide them to this community.
I would encourage, you know, all of the states are required federally to have a community planning group. They are in desperate need of young people, desperate need of innovative thinkers. They don't always, sometimes they can get into a group think where non-traditional folks like yourself who have an interest in public welfare and public health have a space. And so I would make myself known. I would say, I am interested as a college student, you could put it on your resume, as being a member of the Tennessee, right? Tennessee HIV Community Planning Group. I'm interested in that. How do I get picked? You have a unique opportunity to talk about your friends, the people that have had to leave, and also, as it's been mentioned, to express your concern that you just don't see them in the community, and that we need them out there more than what they are, because people are getting lost in the shuffle.
And I think we've been seeing this a lot with certain service programs, particularly in rural conservative jurisdictions. And a lot of it is, like Gretchen said, it's the education and bringing in people who are different. And in particular, we've seen a lot of partnership with law enforcement around certain service programs so that they can talk about the benefits of these programs. And so sometimes it's thinking outside the box to bring someone new to the table that can provide a different perspective that may, you know, hit a mark with the people that you're trying to get that change to happen.
Thank you. So we are right at our time, and I just want to say thank you for your time and attention, and that we do have a very unique opportunity in this moment to will the political will, along with all the research and the knowledge that we have to really end the domestic HIV epidemic. And there's some things that have been laid out from all the presenters around what you all can take back to your members. We also would suggest that you take back to your members as the opportunity to use data to make this stuff come alive. It's really readily accessible and available. And that not only do these organizations, but also there are tons that are not in this room. We stand ready to partner with you in your local districts. We could host tours with you. We could take you to care sites. We could actually engage you with conversation with folks who are most impacted by HIV, and that we are committed to addressing this on a national and an international level. So thank you again for your time and attention, and we are adjourned.